صباح الخير, good morning. I would like to welcome you all to the joint Palestinian-Jordanian conference for endocrinology and diabetes. It is a great pleasure to have friends from different parts of the world, from Italy, from Jordan, from Egypt, from other countries joining us in this second joint meeting. And I would like to open the session about diabetic complications, comorbidities, and related disorders.
Good morning, everyone. I think I have to introduce her. We're good colleagues, like always, and she has done her residency program, and then she has done ophthalmology, and she went through more complicated things and in rare diseases and ophthalmic disease. So any systemic disease with an ophthalmology problems, usually we refer to her. She's the answer for everything. So I would like to thank you. Thank you for, like always, for complicated disease. She doesn't like simple things about ophthalmology. This is piece of cake for her. So since I knew her since many years, she was always willing to do just only rare things and to be brilliant like always. So thank you, Rico.
Thank you very much, Dr. Abdessalam. So the talk will be about advances in the management of diabetic macular edema. We live in the diabetes epidemic, which is a growing non-communicable disease epidemic. The estimated worldwide prevalence among adults in the year 2010 was 285, and this is predicted to increase to around 440 million by 2030. The rise in the prevalence is predicted to be greater in the developing than in the developed countries, 70% versus 20%. In the developing countries, patients who are aged 40 to 60 are affected most, whereas in the developed countries, patients who are older than 60 are affected most. This increase in type 2 diabetes is linked to changes towards a Western lifestyle, with high energy diets and reduced physical activity in the developing countries, and the rise in the prevalence of overweight and obesity. This table shows the numbers and shows the increase in almost every part of the world in 2030 in comparison to 2010. And I want you to pay attention to the countries of the Middle East, where in the Middle East, in 2030, the number of adults is expected to reach 52 million with diabetes in comparison to 27 million in 2010. So the worldwide prevalence is expected to reach 7.7% in the year 2030. Diabetic retinopathy is the most common microvascular complication of diabetes. It is a leading cause of blindness among working age group. It accounts for around 15% of all the cases of total blindness. The incidence is around 2.3 per 100 person years, and it's about 4.5 for patients receiving insulin. So globally, around 1/3 of the patients with type 1 and type 2 diabetes, they have diabetic retinopathy. It is strongly related to the duration of diabetes. With the patients having duration more than 10 years, there is a threefold increase in the vision-threatening complications. At the time of diagnosis, diabetic retinopathy is diagnosed in up to 1/3 of the patients. So if we compare all the diabetic complications, blindness is perceived as the third worst health state after major stroke and amputation. When there is visual impairment, there is increase in the welfare cost, early retirement, and costs of home care and help. For example, in England, in the year 2010, the estimated health care cost for diabetic macular edema was about £92 million, with most of them spent on hospitalization treatment. Overall, the studies show that there is a decrease in the progression to severe visual loss because of better glycemic control and early screening programs. Diabetic retinopathy is associated with a reduced quality of life. The features of diabetic retinopathy as detected by ophthalmoscopy were first described in the 19th century. The earliest features are microaneurysms and exudative changes like hemorrhages and exudates. Later on, there are proliferative changes with the formation of new blood vessels which can bleed and cause vitreous hemorrhage and tractional retinal detachment. There are multiple international studies that have assessed the risk factors for diabetic retinopathy. And these include the level of the blood glucose, blood pressure, duration of diabetes, lipid profile, pregnancy, nephropathy, obesity genetics, and nutrition. Diabetic macular edema can be observed in all the stages of diabetic retinopathy. However, the risk for developing DME increases as the severity of diabetic retinopathy increases. DME is characterized by the accumulation of intracellular and extracellular fluid in the macular area, which is the central part of the retina, thereby contributing to visual loss. Progression to DME is linked to the duration of the disease. If you see, patients who have duration more than 20 years have prevalence of DME of 20%, is linked to poor glycemic control. For example, patients who have hemoglobin A1C 9%, they have a prevalence of around 12% of having DME. In patients with type 2 diabetes, the need for insulin is related to DME, since the use of insulin is a marker of the duration of the disease and the poor control. The number of patients with DME is likely to increase as DME becomes more common. DME is characterized by a breakdown of the blood-retinal barrier. When there is sustained hyperglycemia, there is hypoxia. With the hypoxia, there is an upregulation of the angiogenic factors like the VEGF, like the Ang2, and the increase in the inflammatory mediators. All of these factors together, they result in angiogenic complications and permeability complications. And therefore, there is with time, there is a breakdown of the blood-retinal barrier. However, not only there is microvascular injury, but with sustained hyperglycemia, there is also neuronal dysfunction, which contributes to visual loss. So the advances in the management of DME include advances in diagnosis and advances in management. In 2006, the first commercially available spectral domain OCT was introduced. And since the introduction of the OCT, it has revolutionized the clinical practice of ophthalmology. This is a non-invasive, fast imaging technique that allows us to obtain high-resolution in vivo cross-sectional images of the retina. If you look here, this is a cross-section of the central part of the retina of the macula, and it is very much comparable to a histological section in vivo. That's why the OCT is called optical histology. And these are the features of DME. We notice the presence of intraretinal fluid, subretinal fluid, hard exudates, and we notice the presence of disorganization of the retinal layers. There are robust OCT biomarkers that are associated with visual prognosis. There are some factors that link the outcome to a good visual outcome and good response to therapy. For example, if you have subretinal fluid at presentation, if you have little intraretinal fluid, this may indicate good visual outcome. However, if you see that there is disorganization of the inner retinal layers, what we call drill, or we notice the presence of epiretinal membrane, this may indicate worse outcome after treatment. So the next development will be quantification of these qualitative features. The EURETINA recommends obtaining monthly OCT, even if no treatment is intended, since the morphological changes need to be identified as early as possible. We all know about fluorescein angiogram, and fluorescein angiogram has been a major diagnostic tool to assess the severity of diabetes and all the complications like the neovascularization and the non-perfusion. Although that today there are clinicians who would base the treatment decision on the OCT only. However, the fluorescein, it remains the most commonly approved modality that can differentiate leaking from non-leaking microaneurysms. And in here, you notice that there are areas of new vessels, there are areas of capillary non-perfusion in the fovea, indicating foveal ischemia, and there are more extensive areas of capillary non-perfusion. The advent with the use of the fluorescein was the development of the ultra-wide field. What is the ultra-wide field fluorescein? It allows in a single frame to obtain up to 200 degrees of the central and the peripheral retina. Whereas with the standard fluorescein, we can obtain up to 75%. So now we, the ophthalmologists, we can appreciate more and understand how the peripheral vascular changes affect what happens in the macula, affects the prevalence of DME, the severity of DME, and the response to therapy. So this ultra-wide field fluorescein, it allows us to see more pathology. We can see more areas of capillary non-perfusion, more areas of ischemia, and therefore this has implication for treatment. Since if we see more pathology, this means that we will treat better. And there were studies that showed that with the use of the ultra-wide field fluorescein, we can apply, for example, 3.8 times more PRP than with the conventional fluorescein. We know that laser photocoagulation was the mainstay for treating DME since the 80s. And the efficacy of laser was proved in the ETDRS study, which showed that the laser is beneficial in preserving the vision, but not in restoring the vision once it was lost. And the ETDRS showed that only 3% of patients improved in vision. We know that laser treatment is not without side effects. Many patients will have impairment in the color vision, in the contrast sensitivity, in the night vision, and there might be expansion of the laser marks into the fovea. So recently, we live in a novel era of DME treatment, where the treatment depends on intravitreal pharmacotherapy with anti-VEGF and steroids. The three most commonly anti-VEGF agents, they include the bevacizumab, the aflibercept, and the ranibizumab. Bevacizumab is a full-length antibody, the ranibizumab is an antibody fragment, and they block the VEGF-A, which is a main player in the pathogenesis of DME. Aflibercept, which is a fusion protein, it blocks VEGF-A, VEGF-B, and the placental growth factor. Protocol I, which was published by the DRCR, which is the Diabetic Retinopathy Network, showed superiority of the ranibizumab in comparison to the laser and to the steroids. So if you look together at this graph, so we see in the first two lines the improvement in vision with the ranibizumab. This is over 1 year and this is over 2 years. Greater improvement with the ranibizumab than with the steroids and then with the laser. If you look carefully at the line in yellow, this is the group of eyes that were treated with steroids. And we see that in the first year there was also improvement with the steroids. However, the vision declined later, and this is because of the development of cataract. We know that cataract is a side effect of steroid therapy. So by looking at a subgroup of patients who are pseudophakic meaning patients who underwent cataract surgery, the improvement with the steroids was comparable to the improvement with the ranibizumab. We have the 5-year follow-up of the Protocol I, and vision that was improved in the first year was maintained all throughout the 5 years of follow-up. And if you pay carefully attention to this table, you notice that there is a decline in the number of injections, meaning that in the first year, the patients needed to receive around 9 injections of ranibizumab, in the second year 4 injections, and by the 5th year almost no injections were needed while maintaining visual improvement. Here we see the decline in the central macular thickness, and we notice in violet or purple the eyes that were treated with laser, less decline in the central macular thickness. The use of ranibizumab did not only result in improvement in DME, however, it also improved the severity of diabetic retinopathy. And in these two graphs, we see improvement in the severity score of PDR and NPDR. Bevacizumab efficacy was shown in a smaller study, and the study showed that over 2 years, the eyes gained around 8 letters, in comparison to loss of 0.5 letters with the laser, again with a reduced number of injections. Aflibercept was studied in phase 2 and phase 3 studies. One study was the Da Vinci, which evaluated different doses of the aflibercept, 0.5 versus 2 milligrams, as well as different dosing regimens, monthly, bi-monthly, or PRN, compared to laser. And if you look carefully, you notice that there is improvement in all the arms that received the aflibercept. The biggest improvement was by using the higher dose of aflibercept, 2 milligrams every month, much more than using the aflibercept every 2 months. And here you notice the decline in vision with the laser therapy. The benefit of aflibercept was proved in 2 big phase 3 studies, the VIVID and the VISTA, where we see here with the use of the aflibercept, 2 milligrams every 4 weeks or every 8 weeks improvement by about 12 letters compared to no improvement almost with the laser therapy. Here we notice the decline in the central macular thickness, and there is very little decline with the laser therapy. And if you pay carefully attention to this graph, you notice this oscillating pattern of using the aflibercept every 2 months, or the sawtooth pattern, indicating maybe under treatment while using the aflibercept every 2 months than every month. However, this didn't have any adverse effect on the final visual acuity. The New England Journal of Medicine published in the year 2015 Protocol T of the DRC-RNet. And in Protocol T, the aim was head-to-head comparison of all the 3 anti-VEGF agents. Before its publication, uncertainty existed regarding the relative efficacy of each one of these agents. However, Protocol T showed that all 3 agents were effective in improving the vision in patients with DME. By looking at a subgroup analysis of patients who had lower visual acuity, less than 20/50, aflibercept was superior in the first year to the other 2 agents. However, the difference was not maintained between the aflibercept and ranibizumab in the second year. There was no difference in the ocular safety profile between the 3 agents. There was no difference in the number of injections. There was a slight increase in the systemic side effects with the ranibizumab in the vascular deaths and the non-fatal MI. With the aflibercept, there was less need for laser. And actually, with the aflibercept, there was improvement of the severity of PDR in comparison to the other 2 agents. So the Protocol T concluded that all the 3 agents had acceptable ocular and systemic safety profiles to be used as a first-line therapy for DME. The Protocol T showed that eyes can improve the vision, and the vision that has been improved in the first year can be maintained all throughout 2 years. We know that aflibercept and ranibizumab, they are expensive treatments, and that's why they are not cost-effective when compared to the bevacizumab. We have mentioned earlier the role of inflammation. We said that inflammation plays an important role in the pathophysiology of DME, and that's why there is a role to use intravitreal steroids. Since the steroids can block the inflammatory agents, the androgenic factors, they can inhibit leukostasis and enhance the barrier function of the blood-retinal barrier. We know that the earliest evidence comes from the Protocol I, which showed that pseudophakic eyes that receive steroids can improve in a comparable way to the ranibizumab. And we have the results of 2 big studies studying implants that can be injected in the vitreous and releasing slowly the steroids. One implant is called the dexamethasone implant, which releases the steroid over a period of 6 months. So in the MEET study, 2 doses of the dexamethasone implant were compared to sham, 0.7, 0.35, and sham. And after 3 years, we notice with the higher dose of the dexamethasone, there is more improvement in the vision. But as you would expect, that with the steroids, there are always complications. The most common complication is cataract. Around 70% of the eyes had cataract compared to 20%, and more eyes needed treatment for increase in the intraocular pressure. Another treatment is the FAME, which evaluated another implant, which is described to be like the size of a rice. And this implant contains fluocinolone acetonide, and it delivers the steroids over a period of 3 years. It was studied in 2 doses, 0.2 or 0.5, and compared to sham. And again, more improvement in the vision with the steroid implant than with the sham. However, the bigger improvement was with the patients who have chronic DME than the patients who have acute DME. And more patients developed complications, of course, with the higher dose implant than the lower dose implant. Therefore, because the benefit to risk was better for the low dose implant, it was approved by the FDA, and it was approved in Europe to be used for patients who have chronic diabetic macular edema. So we live in a period of challenges because we need frequent injections. This is really a treatment burden for patients. Not all patients are able to come to the clinic on a monthly basis to receive the injections. Still, not all the patients are responders. Some of them are partial responders, some of them are non-responders. We know that up to a quarter of the patients, they will still have marked macular edema. So there is always the need to look for additional treatment options. So what is in the pipeline? Faricimab is currently studied in big phase 3 studies. It is the first bispecific antibody that can target and block two agents. It can block VEGF-A and it can block angiopoietin-2, since both of them are important players in DME. It was shown in phase 2 study, the Boulevard, that faricimab demonstrated statistically significant visual acuity gains and has potentially maintained disease stability longer than ranibizumab. And now it is studied in Yosemite and Rhine studies, head-to-head comparison between the faricimab and the aflibercept. Another option that is studied is the ranibizumab port delivery system, which is a small intraocular implant that can permanently be sutured to the eye wall, and it can be refilled every 4 to 6 months to deliver ranibizumab. Therefore, the treatment burden can be reduced for patients, and this can also address the issue of under-treatment. So in conclusion, diabetic retinopathy is the most or the major cause of visual loss in patients with diabetes. Patients with diabetic retinopathy, they need lifelong attention with versatile treatment options. Diabetes is a severe and chronic systemic disease which must be managed systemically by expert physicians. Early ocular intervention is very important. Solid communication between the diabetologist and the retinologist is crucial. Recent advances in the diagnosis and the management of DME has improved the management of this major clinical and public health problem. And I would like to thank you very much for your attention.
Thank you very much, Doctor.